Okay, thank you all so much for being here. It is truly an honor to welcome the College of Medicine to the Archaeology Museum. And so I'd like to introduce our speakers, and they have amazing biographies. And so I want to give them all the accolades they deserve by reading these. Dr. Trimm is a developmental behavioral pediatrician, and he has been a medical educator focusing on medical education for more than 30 years, with areas of emphasis including curriculum development and educational leadership. He has served as the president of the Association of Pediatric Program Directors, chair of the American Board of Pediatrics Education and Training Committee, vice chair of the ACGME Pediatric Regency Review Committee, chair of the American Academy of Pediatrics Committee on Pediatric Education, chair of the Society for Developmental Behavioral Pediatrics Education Committee, and also served on the SDBP Board of Directors. He has developed and presented multiple workshops that focus on learner, faculty, and administrator development at a variety of regional and national meetings, as well as sessions focusing on diversity, equity, and inclusion. He has facilitated multiple sessions on unconscious bias for health professions students and professionals. He served as the Pediatric Residency Program Director at the University of South Alabama College of Medicine for 25 years. He is now serving as the Associate Dean of the College of Medicine and Assistant Vice President of Medical Affairs for Diversity and Inclusion. So thank you, Dr. Trimm. Tiquera Hall. She's very special here at the museum. She's been our guest time and again, and we're so glad to welcome her back. And she's actually going to give this presentation tonight. She is amazing and also an education and training specialist for the Office of Diversity and Inclusion at the USA Whiddon College of Medicine. She is dedicated to fostering and implementing training and workshops related to cultural competency, structural competency, health disparities, and health inequities related to marginalized populations. She has devoted her time in higher education by creating spaces and conversations about women empowerment and injustices of marginalized people. Tiquera has a knack and a passion for curating epic experiences that exhibit positive changes in mindsets, behaviors, and attitudes through powerful integration. Ms. Hall is currently pursuing her doctoral degree in instructional design and development and has received her master's degree in public administration from the University of South Alabama. Tiquera's goal on her journey is to do my best to educate, promote, inspire, and create. I will educate the forgotten and the unknown, she says. Promote the underrepresented, and underserved. Inspire spaces where I'm absent, yet present. And create content that connects gaps by cultivating inclusivity. So I hope you'll join me in giving a very warm welcome to the College of Medicine and Ms. Hall and Dr. Trimm. Thank you so much for being here tonight.
The reason Tiquera is giving the talk is this is my full voice this afternoon. So y'all are very fortunate to have to get to listen to just Tiquera. Okay.
Hello, everyone. I'm Tiquera Hall. As Ms. Jennifer has introduced me, I want to thank you all for inviting the College of Medicine and Office of Diversity and Inclusion for coming to you all to speak about Where's the Parity? Exploring the gaps between health equity, health disparities, and health equity. Okay, sorry. So our focus today on our talk will be to define health equity, define health disparities, and explore causes of those gaps, and then advancing health equity, focusing on how we can do that. So health equity means that everyone has a fair and just opportunity to be as healthy as possible. So basically, we're saying that health equity means social justice in health. And its underlying commitment to health equity is to reduce, ultimately eliminate any disparities in health determinants or social determinants. And we'll go deeper with explaining those social determinants. So pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to those who are in need and who are at greater risk of poor health based on those social conditions. So when we think about what determines our health, the conditions and the environment where we live, where we are born, where we learn, where we work, where we play, where we worship even, and depending on our age, are wide ranges of things that impact our health when it comes to our functioning and our quality of life. All of these areas impact our biological function. Basically saying the longer and the more intensively adverse influences are experienced, the more progressive these negative impacts can have on health equity, on our disparities also. So health disparities are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. So I wanted to explore the piece that focuses on disadvantaged populations. So basically saying that adversely, these affected groups can include groups that are systematically experiencing greater social or economic obstacles that are focused on their racial and ethnic group, their religion, their social economic status, their gender, their age, their mental health. Also looking at the cognitive and sensory and the physical disabilities, their sexual orientation or their gender identity, geographic location, and other characteristics such as they may be historically discriminated against when it comes to health or excluded. So health disparities basically is a metric we use to measure the progress to measure the progress of how we are striving to achieve health equity. So health disparities that are driven by our social and ethnic inequalities, basically this is the social determinants of health. And they're driven by these six categories, that are social economic status, education, and neighborhood focus, social support systems, whether we have food, and also looking at our community where we live, that environment piece, and also the healthcare system. So these are all different factors that are driven by health disparities that informs whether or not we have health equity at the end. And also wanted to point out in the middle of the screen, if you see the gray banner, focuses on racism and discrimination. So all of these things are adversely impacted by racism and discrimination. And in the orange banner at the bottom of the screen, you're seeing that these impacts of social determinants of health are causing mortality, life expectancy. They are all focusing on these outcomes when it comes to the health and well-being of people. So let's take this a step closer. So looking at, let's say we have a patient, and patient is a Black male who is obese and has hypertension, high blood pressure. So despite being prescribed medication for hypertension or blood pressure, despite being prescribed prescriptions for high blood pressure, the patient is still experiencing elevated levels of high blood pressure and also struggles with maintaining weight. And all of these things, I'm going to give you examples of how this plays impact with the social determinants of health. So let's say this patient has 2 jobs, and they have these 2 jobs to support their family. The guy on the screen has 2 jobs to support their family, but they earn a low income, which impacts their inequality of their earnings. So they struggle to meet their basic needs. And with this, they're living in a public housing or project housing area, which in that environment, their sidewalks are not easily accessible when it comes to exercising. They may have some damaging, or they may be even non-existent. So taking you through the next step when it comes to how education can play an impact on this particular patient. Say the patient has minimal education, graduated high school, maybe received the GRE, but when it comes to health literacy, understanding the prescriptions that was provided for him and being able to understand the importance of the medicines that are prescribed to him, there may be a gap there when being able to understand that piece. Moving forward, we're looking at food. So as I stated, this patient works 2 jobs. So we all know when we're busy, the easiest thing for us to do is pick up fast food. It's easily accessible. It may not be the healthiest option, but pick up fast food. So having to pick up fast food, but when we think about the location of where this patient lives, across the street, there's McDonald's and a convenience store are the 2 closest stores in proximity to where this patient may live. Another caveat to that is the community and the safety piece of that, and adding on transportation, which to mention that piece. So the patient does not have transportation. They had a truck is no longer working, so they're catching the city line, so having to walk a distance to get to that city line. Going to the first job, second job, they're catching a ride with someone else to get to provide transportation, just showing that there's a lack of transportation there. So tying it all together, you then have the environment piece of this patient has been exposed to violence due to the area they may live in. So they've been growing up around violence. It has caused different trauma. So going out to just, I'm going to go on this nice walk may not be something first step that patient may choose to do. And how does it impact the healthcare system? Has insurance, minimum level of insurance, but may not have the transportation, as I was discussing, to be able to go get those prescriptions. May not have the funds because you're choosing whether to feed your family or to pay the light bill, the water bill, to make sure those basic needs are still taken care of. So all of those factors are playing a part and has an impact on the outcome, which in this case, as I started the case by saying, despite being prescribed medication for the hypertension, you have to think about when it comes to these social determinants of health, what this patient is experiencing on a daily basis. They may not have access to get to those pharmacies or money to buy the prescriptions that's needed. And it's just important to know that these determinants are all impacting this patient's outcome. So looking deeper into health disparities, I wanted to point out here that it's important for us to note that health disparities can last across generations. It's not something that someone may just experience, but they can last, one person may experience, but their grandmother, their great-grandmother, or our parents may have also experienced. Also knowing that there are other factors that can close the gap with addressing these different disparities, and also knowing that other disparities, say in particular the African-American community, are HIV, cancer, dementia, infant mortality, which we'll discuss a little more later on, and childhood obesity. Also want to point out at the bottom of the screen, discrimination can also look like income inequality, but also disability. Just wanted to re-highlight that piece. So health disparities does not look like one thing. It can look like a multitude of things, but also knowing that those social determinants are driven by the disparity that patient or people that are experiencing. And different causes to these, to the health disparities. One thing I think is important to focus on here, as I talk about the generational lasting of these health disparities, when a patient is experiencing a mistrust to the health system, it's important to note that that mistrust, that can be something that they've heard from their father or their grandfather that, oh, we're not going to the doctor. We don't believe in going to the doctor, or people die when they go to the hospital. Just the believing factor that can also have a generational impact that is informing due to their parents having a lack of trust to the healthcare system. So in our 8 defines different health disparity populations. So they broken it down to different categories. It talks about the racial and ethnic minority groups, American Indians, Alaska Natives, Asian Americans, Black and African Americans, Hispanic and Latinos, and Native Hawaiians and other Pacific Islanders. When it comes to another disparity population, there is sexual and gender minorities. So basically, these are groups that identify as LGBTQ plus, lesbian, gay, bisexual, transgender are also minorities that are discriminated against. And then people with lower socioeconomic status, and in particular for this session, this is looking at people who grew up also. It just adds another caveat. Growing up in a lower economic status also has a effect on it. Even though you may have moved on and lived somewhere different, it still had an impact on the disparity that you went through as a child. And then looking at underserved rural communities and people with disabilities. And when you're tying it all together here, it's basically saying that wanting to focus on the race and ethnic minority groups here. Although it's important, this is focused on our geographic ancestry. So basically saying that race is not a biological construct, it is a geographical construct and social construct, sorry, that we will dive in deeper in more. So I just wanted to point out here, we, society, define race by a social, by a biological construct, but this is a social construct. So taking a look deeper, closer, wanting you all to kind of look at and see different examples of some well-documented findings when it comes to different inequalities based on race and ethnic groups. And this is all compared to non-Hispanic whites. So taking a look first at the Latino health inequalities, when compared to whites, Hispanic Latinos are more, they experience diabetes 63% more than whites. ESRD, which is basically saying that end-stage renal disease, people who are on dialysis at 34% more than white population. And then they die from diabetes 33% more than the white population. And then have cervical cancer 25% more compared to whites, and then die from cervical cancer 18% more compared to whites. And to get a closer look at the health disparities for Latinos, inequalities, this is based on children. Looking at American Indian and Alaska Native health inequities. So when compared to whites, diabetes, they have 2 times more the rate. They die from diabetes, 2.4% more, experience obesity 33% more, and depression 37% more. And once again, wanting to focus for you all to go through how it impacts children when compared to non-Hispanic whites. When looking at African-American health inequities, when compared to whites, African-Americans experience diabetes 72% more, HIV times 8 more, obesity 23% more, cervical cancer 52% more. And maternity mortality rate, which I said we'll talk about in just a moment, is 3 times more. And looking at how African Americans' health inequities impacts children. So as we've been going through the documented findings of all, wanted to point out here that African Americans of all ages are negatively impacted by these health disparities. And they all die at an early age due to these different experiences. As you can see at the top, when it compared to high blood pressure, this is comparing it to non-Hispanic whites, high blood pressure, diabetes, and stroke. And just thought this was very important when I first found this. It's like, okay, this is not just happening to an older population age gap. This is also occurring in younger people also. So coming back to the genetic ancestry when it involving the geographic piece, wanted to point out here, as I stated, that race is a social cultural concept. It is not supported by genetic and biological evidence. So just thinking here, pausing for a second, have any of you all did 23andMe or okay? So when doing that, when you received your results, did you receive it based off your race? So to answer, it was not a quick trick question, but to answer it for you, it is not broken down by race. It's broken down by the geographical ancestry. It tells you based on locations where it is, and that's how race is defined by society. We put it on based on these social cultural concepts, and just wanted to kind of bring it in as an example there. So basically looking at the variability of DNA from person to person is high amongst members of the same race, even across all humans. And looking at biomedical research, it's often self-reported. And you think about the race as self-reported, it's not something, it's self-reported, and I want to connect that thought, self-reported based on how society has been defining us and how we've been told throughout the years to identify ourselves. And looking at a proxy for a measurable indicator of group differences is also important when comparing it to the social determinants of health. So building from that piece to illustrate the proxy for a measurable indicator of group differences and social disparities, I want you to look at the chart here explaining basically poor and fair health amongst all adults in racial and ethnic groups. So across the bottom of the screen of the chart, the graphic here is the different races, Black, non-Hispanic, Hispanic, Asian, American Indian, and Alaskan Native, and then other than white non-Hispanics. On the left side of the screen, you can see it's broken down by the percentage of years when it comes to poor and health disparities and outcomes. And if you see, starting off with Black and non-Hispanic, probably right at 45%, what you're able to tell, and it's based off the educational attainment here on the top right of the screen. So the darker shade color across all categories is saying that that percentage of people who have only a high school degree are experiencing poor health outcomes more. And going down to the next category, less than high school was the first category, the darker shade. The next shade is people who have graduated high school. And then the next column has some college. And the lowest one is not listed on the screen, but are people who graduated from college. And if you look across the trend here, there's a pattern here that shows regardless of race, when it comes to education attainment, it has an impact on the social determinants of health, which, as going back to it, education is a social determinant of health. So one thing also to point out here is basically there's an inability to complete education based on the high school, college degree. Is more prominent in more race groups than other groups. And this is all driven by not just education, but not just race, but other social determinants of health. So when combining race and gender, it's important here to look at for you to see here that maternal mortality is the most prominent health disparities across the health disparity. period, across the US. So this article was inspired by Serena Williams. And basically, she was giving birth in a hospital, at a top tier hospital at that. And knowing Serena Williams, she has some coins, she's well paid, but she was basically ignored. She was ignored, and when she complained about having abdominal pain, and it caused other problems and issues, in which kind of, even though women were experiencing this before Serena, but it kind of sparked even more notice to what was going on. So Black mothers in the US die at 3 to 4 times the rate of white mothers. And it is once again, one of the most racial disparities and health disparities that we have. So taking a deeper look at this perspective. So compared to a white woman, a Black woman is 22% more likely to die from heart disease, 71% more likely to perish from cervical cancer, and 243% more likely to die from pregnancy and childbirth related causes. And what's important to also note here, that regardless of, and when it comes to this disparity here, regardless of your socioeconomic status, it had an impact here for Black women. As I stated, I used Serena Williams as one example, but regardless of the education as we've shown, but regardless of education, regardless of any other social determinants of health, especially the socioeconomic status, Black women still die at a much higher rate. So looking at health equity, advancing health equity is when everyone has the opportunity to be as healthy as possible. So I wanted to talk through some different options here. So every year, 100,000 Black men, women, and children die because of their mortality rates due not equal to their white counterparts. So if you look here, this statistic means that if disease and mortality rates for Black people were the same as for white people, we would stop and think about it this way. So if you think 275 people going on a flight every day, and that plane crashing every day is compared to the 100,000 Black men and women and children experiencing health disparities and dying from these health disparities. And if we think about it, if a plane was crashing every day, as I stated, 270 people on the plane, if a plane was crashing every day, it would raise a lot of concern. That plane would be pulled off to the side. It would have a lot of issues. We would know about it across the news. But just wanted to compare the 100,000 Black men and women and children are dying at that same rate. So when striving for health equity, we're going to discuss this through 3 different domains here. And when looking at the social determinants of health, it's certainly important to look at it here. And today we're going to bring it home based on how USA Health System and USA Whiddon College of Medicine is looking through this lens. And we look at it through research, the workforce, and education. So when looking at it through research, it's important to note that inadequate representation of health disparity populations, when we're looking at research scientists and NIH funding committees and subject participating in clinical skills. And it's important that we've been working, for you all to know, we've been working with IRB and clinical trials teams to help ensure we are using race appropriately when we're doing research studies, to strengthen those representations across the study. So it's important to have that visual representation when it comes to these clinical trials, and that those things are being practiced against all populations, so that when you're putting in this information on the back end, you're having that information. So the results here is that treatment protocol studies only in segments of population here can increase, when you don't have it, it can increase the health disparity. And our goal is to kind of mitigate this by providing the education piece within the research focus to advance health equity overall. When looking at the workforce, minority patients report better communication and satisfaction and adhere when cared by a racially and linguistically provider. And long-term study of patient-physician with Black male patients, it's reported here that Black doctors are more likely to write additional notes about the subjects. CV disease impact was significant, leading to a 19% reduction in the Black-white male gap when it came to cardiovascular mortality. We're looking at diabetes and cholesterol screening and invasive testing were up 20%. And when it came to flu shots, it was significantly more likely to occur. And I think all of these things definitely in play with when I was discussing the trust in the health system, where you're able to see someone who can relate and just adds on to that that visual representation and takes the piece to talk to the patient. And when it comes to minority physicians, they're more likely to serve in the underserved communities. So let's look at how this let's see what this looks like here in the US today. So when looking at the representation and communities served, here you can see basically showing that this 60% of doctors and with that is compared to each percent within the US population, broken down by racial ethnic groups. So for instance, the population, US population for Black and African Americans, a little over 10%, but when it comes to doctors, the representation there is less, I would say less than 10%, around 6%. I just want to show you how today the communities we serve. And these same populations underrepresented in medicine experience the starkest health disparities. Black physicians, we're looking at here, the proportion of US physicians who are Black has increased by only 4% over the past 120 years. And the share who are Black men remains unchanged since 1940.
He's one of our own, for those who can't see that logo. That's Dr. Antoine Hogue.
Yes, Dr. Hogue. When focusing this through education, it's our goal to prepare future and current healthcare professionals to provide culturally aware and responsive care when we're trying to tackle these health disparities and provide and achieve health equity. And we're doing this through 4 different pillars. We're addressing bias and stereotypes, stigma, addressing microaggressions. We're providing cultural competency, talks and discussions and trainings, and this is also starting within the medical school, along with expanding this through the healthcare system. Also focusing on cultural humility and having conversations around social and structural determinants of health.